my name is Dr. Woods from Inova Fairfax Hospital, and I'm here to talk with you today about ocular ultrasound. We are going to be scanning a healthy eye today, and I'm going to be pointing out a couple of features that you would look for in cases of patients for whom you're concerned about increased intracranial pressure or retinal detachment. So the first thing that I start with is a Tegaderm. This is to protect the patient's closed eye and allows for increased comfort of the patient. Next thing I'm going to do is make sure I have the correct probe selection and settings on my ultrasound machine. So I'm using a sonocyte export, and what I'm going to do here is go into my controls and select my high frequency linear transducer, and I'll show you this here. Okay, we're looking at a superficial structure, so I want to use a high frequency probe to show me lots of detail at a very, very shallow depth. I'm going to go into the settings for this particular transducer and choose ophthalmic, okay? And the reason for that is this is going to generate much less heat associated with examining the eye. Once I have the correct settings on the machine and the transducer selected, I'm going to prepare my patient. So I have the patient relaxed on the stretcher, head up at probably about 45 degrees, which is comfortable. I've explained to my patient what I'm going to do in advance, and I'm going to use the Tegaderm on the eye. This will not pull off eyes and eyelashes, as long as not too much pressure is applied in putting the sticky on top of the face. So I'm going to have my patient go ahead and close both eyes and just relax the face, so you don't want your patient to be squinting, and you're just going to feel sticky plastic over your right eye. This is my gloved hand right on the side of the face. And I'm going to go ahead and place the Tegaderm right on top of the eye and just very gently touch the closed eyelid with my finger, just to adhere the Tegaderm. My next step is to peel the paper and just touch the medial canthus or corner of the eye with my finger, okay? Peel the rest of that paper off and then touch the lateral canthus or other corner of my eye. I'm not smoothing the Tegaderm over the skin. What I'm doing is pushing out the air bubbles. This is very important. Air is the enemy of ultrasound, and we'll take that beam and just scatter it, okay? So you don't want any air between the Tegaderm and the surface of the skin and your probe. So now that I've made sure that there's no little air pockets there, is that comfortable for you?
Yes.
Great, okay. So then what I can do is actually just apply a nice kind of medium-sized layer of gel right on top of the eye, okay? None of that's getting on the skin, and that's comfortable for the patient. From here, I'm going to orient my probe, marker to my left shoulder. Marker is on the screen on the left as well, so left is left is left. And I'm going to rest the heel of my hand right on the patient's cheek. Okay. When I do that, what I've got here is a beautiful picture of the globe, okay? Nice round structure. Now the goal here is to apply as little pressure as possible to the eye itself, and you'll see that there's a little bit of flattening right up here at the top, so I'm putting even a little bit too much pressure there. So I'm gonna kind of ease off my pressure a little bit. The idea is I want to keep that nice round convex appearance of the front of the globe, okay? That means I'm not applying any pressure at all. As we look here at the eye, let's point out a couple of features. This is the lens that you see right here, okay? This is the iris right across here, and then you've got the nice open anterior chamber, all right? So that's the first thing I do, is I look at the anatomy of the eye. The second thing that I do is I look inside the globe itself. Am I seeing any bright hyperechoic features? Am I seeing anything that would look like syndicii? And then importantly, as we often do this exam for the question of retinal detachment, I'm looking for any peeling of the retina off the back of the eye. Now, important to notice here is that the retina itself generally will remain adherent over the optic nerve, and you see the shadow coming down here. So the retinal detachment, when it is seen, will often come off the eye in either an asymmetric line extending from here or in a V shape, okay? So you'll see a single bright white or hyperechoic line coming off from this center point here and this center point here, almost coming off like a V. And as we're looking here, we're seeing a nice smooth layer behind the eye. Now, what I like to do in the cases of trauma, very gently, of course, not applying any pressure to the eye, is assess extraocular movements. That's a tough thing to do when you've got a periorbital hematoma. So what I'll ask my patient to do is follow a few commands. So go ahead and look left, Dennis, and look right, and look up, and look down. And so what I can see there is he's got full extraocular movements there, and again, really nicely delineated lens and iris here. Now, the last thing we're going to look at is the optic nerve sheath. So I'm going to have him do an extraocular movement so that that nice shadow comes all the way down. Look forward, Dennis. Okay, all right, there you go. So freeze is, so I just hit it down here, and then I can slide this to unfreeze. Perfect. Okay, and then from here, I'm just going to go back a couple of frames. So once I'm able to obtain a shot with the shadow created by the optic nerve sheath, I can remove my hand from the patient's face and let him or her relax. Here what I'm going to do is 2 measurements, okay? I'm going to hit my distance button here, and I'm going to use this, and I'm actually looking up at the top screen here, and I want to start at the back of the eye, and I want to measure 3 millimeters down. So again, I'm controlling with my finger on the small screen, but looking up at the top screen. And you can see those yellow numbers in the upper left-hand corner of the screen. And I've got 3 millimeters down. That's due to the artifact created by the globe itself, and I want to measure appropriately back from the posterior aspect of the globe to get an accurate measure of the width of the optic nerve sheath. So then I'm going to hit distance again and make my second measurement. And I'm going to do it right at the end of that 3 millimeter distance, right here at the edge of the shadow, and come here to the edge. And I'm probably a little generous on that side, so I'm going to come in again. There we go. So typically we start to be concerned about raised intracranial pressure when we see measurements that are approaching 6 millimeters. The data for this has not been well validated and continues to be looked at and studied in the literature, but the original studies looked at measurements of 5.5 millimeters and greater, approaching higher sensitivity and specificity for raised intracranial pressure, the higher the numbers are. A couple last things I look for, I look at that normal anatomy that we talked about in the beginning, identifying the lens in the anterior chamber. Sometimes you can see a lens dislocation. Any bright, really pinpoint areas that you don't expect to see in the globe can be significant for foreign body. Especially metal foreign bodies. So that's really about it. And remember that the buttons to measure things like this are going to differ for every machine, so this will not apply to anybody who's not using a sonosite export. So measuring distance, it's important to be comfortable with your machine before you have a patient prone and under the in action, so to speak, for your exam. So when I am measuring distance, I know that my distance buttons for this particular machine, and this may differ for your machine, are here. So I'm going to go ahead and hit distance. When I do that, I get this little circle here. I'm moving the circle on the bottom screen, but actually looking up here at the top screen, and you can see that corresponding yellow dot. I have some measurements on the screen that I've already left here. We're just going to repeat those measurements. So again, when you're measuring the width of the optic nerve sheath, I'm going to measure 3 millimeters down from the posterior part of the globe, which is here. Here's my yellow dot, so you'll keep your eye here. I've got my finger here, and I'm just going to move that dot where I want it, right there. Okay, once I let my finger go, it anchors. Then what I'm going to do is take my finger on the second dot and move that back where I want it to be, right about at the same distance. Then I'm going to go ahead and hit my distance button once again, which is here. Okay, and put that right where I want it, right at the edge of the optic nerve sheath, and then take my second button, okay? And move that where I want it, right there, and let go. And that gives me the distance that I want right there. And again, we start to worry about raising a cranial pressure when we're measuring optic nerve sheaths that that exceed 5.5 millimeters, approach 6 millimeters, and then of course as they get higher, we have a higher index of suspicion.